So Henri MONDOR, that's in the Créteil site. That's the hospital you see there in the back.
Exactly, that's the drawing of what it is actually like. Because I find that the drawing is sometimes better than the real life. So, but it's a hospital located 15 kilometers away from Paris. It's connected by the subway, and it's a large hospital with 900 beds, and we have the chance to have 4 CT systems now. So it's we are just starting to be able to do the imaging we like. So it's good.
I see. I understand that you also know our CEO, actually, Jean-Luc Procaccini, who also lives in Paris.
Yeah, absolutely. And maybe we can meet at JFR. I don't know.
Yeah.
Okay, thank you. And I would like to wish you all most welcome to today's MedTechLabs Seminar. And Professor Mats Danielsson will introduce today's lecturer, Alain LUCIANI. So please, Mats.
Yes, so we are very happy to have Professor Alain LUCIANI here from Paris, one of the most renowned researchers in his field in the world and in Europe. And Professor LUCIANI is a professor of radiology at the Faculte de Sante of Créteil, Université Paris Est Creteil. And he works at the medical imaging department of the Henri MONDOR University Hospital, where he also is a medical director of something with as nice name as FIxIT. That sounds very promising.
It is. Okay.
Which is short for Fonctions Images Interventionnel Thérapeutique.
That's it. Yeah.
There you go. He is also very active in a number of international organizations, and right now, as I understand, responsible for the research committee in the French Society of Radiology, which I guess means you're in charge of the money there. So that sounds important.
Sadly, we only have research without money. That's the French way to go. But anyway.
I see. So please, Professor LUCIANI, go ahead. We very much look forward to your lecture.
Thank you, Mats. Thank you for the invitation. Very happy to be here. As I said, the face-to-face meeting would have been even more, I think, appropriate for questions. But I do hope that we will have some questions throughout the lecture that I will try to provide. So the idea was maybe to state the current applications and ongoing questions that we have in applying spectral imaging to abdominal oncology, which is my main topic. Just some disclosures, and then I will kick on in my presentation. I think if we look at the CT challenges on a clinical basis and a clinical perspective from the radiologists, I mean, those are some of the challenges that we have to address in the near future. Of course, dose reduction. And dose reduction, I will also like to connect to the restricted use of iodinated contrast agents. So it's a dose reduction in terms of X-ray delivery, and of course, dose reduction in terms of contrast agents. But that should not mean that we would degrade the native contrast between what's normal and what's pathologic. And I think that's very important that we still keep a very high-end analysis of the CT images that we performed. And with that, as we all know, CT faces a huge challenge with this workflow, increasing the number of patients that we can address in the same time, having more information provided to us. How can we cope with that? So those are the basic challenges. And I think that's where actually spectral CT kicks in. Because if we compare the conventional CT with spectral CT, actually, we must not forget, of course, conventional CT is based on a polychromatic spectrum, where the material analysis is based on the material densities. And those densities in Hughes-Field units are calculated based on all X-ray beam energies. And that means that the attenuation that we measure is actually only partly related to the material composition, which means, and that's everyday practice, that some attenuation, that we can have the same attenuation for different atomic numbers. Now, spectral CT goes a little bit further, of course, because the analysis is based on the attenuation spectra observed at 2 different energy levels. That's the principle of dual energy. And that's what we are currently experiencing at Henri MONDOR. And now the material analysis should better reflect atomic numbers. Is it true? Well, we are not there yet, but actually we will show how, because those spectral CT are more sensitive to materials of high Z atomic numbers, especially by optimizing photoelectric effect, that can have an impact on the way that we use that in clinical practice. Now, if we look at the different the physics behind the scene of being able to provide dual energy CT, of course, we have different systems with different vendors, different capacities. Some very enthusiastic, of course, option is to use the dual layer detector, because that means that anytime without any temporal, with optimized temporal resolution, you can have the benefit of dual energy. Some of the vendors have used sequential acquisitions or twin beam CT or dual source dual detectors. And I will only provide images that are performed at Henri MONDOR and that are all based on rapid switching dual energy CT, which means a change at the emission and changes in the detector. So all of my talk and all the images that I will show will be from this rapid switching dual energy CT provided by GE. Now, I think one of the main changes when using spectral CT is that it's a huge change, a shift in the way that we deal with the images. And I think CT is even closely related to MRI because we use spectral CT. And that's what I call the sequence paradigm, is that we are all used to have CT images just being poured down to the PACS system and reading huge quantities of CT images. But that's not what spectral CT provides. Spectral CT provides sequences exactly the same way that we have sequences in MRI. And basically, I would say the three sequences on the basic of all spectral CT acquisitions is, first one is virtual monochromatic images, that is reconstructed images at different energy levels, and especially at low energy levels, because they will optimize the attenuation of materials with high atomic numbers, such as iodine. So that's the first sequence that we have, virtual monochromatic images. The second sequence that is very useful is actually material decomposition images. That means it's also reconstructed images. We are not talking about Hume's field units attenuation, but rather the relative concentration of one material related to the other. And of course, in oncology, having a map showing the relative concentration of iodine within an organ, a tumor, something which is a normal, compared to the adjacent organ, can be very useful. And I will try to illustrate that in the rest of my talk. And the third sequence is, of course, the resultant of the material decomposition images. If you're able to distinguish the relative concentration of iodine over water, that means that you can extract the map of water and you can provide a pure kind of water map. And that's the virtual non-enhanced sequences that are provided with spectral CT. Now, those are the three basic sequences. And as with MRI, you can multiply those sequences because you can use different monochromatic reconstructions. You can see different materials. And that's where you will see that actually you do not gain time using spectral CT, but probably you gain quality. And I think that the main advance of those spectral CT system is that actually it's better quality provided to the patient. So if we look at the recent publications, and I focus on applications of spectral CT in oncology. Now, I would say that the innovation is now clearly integrated in clinical practice. There have been multiple applications of spectral CT in oncology. Of course, in the liver, showing how spectral CT could enhance the detection of hypervascular lesions, but also of hypovascular lesions. And I will focus on that because that's a very important part, especially for the detection and characterization of primary liver cancers. But that has also been the case in pancreas, that has also been the case in kidneys and also in lung cancers. But with those multiple applications, I would say that one of the most, I think, interesting papers that we must focus on is going back in the past, in 2011, and seeing that paper of those colleagues published in radiology to understand how spectral CT must change our practices. Now, I will just comment the papers that was done. It seems a pretty much simple paper. The authors focused on the way they could address the image quality obtained on spectral CT as compared to conventional polychromatic CT. Now, one thing they did is they put in a phantom evaluation using 4 syringes with diluted contrast agents, and they addressed the contrast to noise ratio at different energy level with a window that was set at exactly the same path, and they just measured the contrast to noise ratio. Now, what's the conclusion of those authors that we must apply to clinical practice is that when you see those different attenuation values, of course, you understand that where there's iodine, the lower you go into the energy levels, the higher attenuation value you will get. So you would tend to say, okay, let's reconstruct the lowest virtual monochromatic energy level. But what the authors also showed is that the contrast to noise ratio does not follow that same linear or exponential path, but rather it goes by a maximum and then decreases, whether you go for low energy levels or high energy levels. And why is that? Because there's a minimal point where you minimize the noise and you optimize the contrast. And the conclusion of the authors that we must apply to our clinical practice is that it is mandatory to identify the monochromatic energy level, providing the optimal contrast to noise ratio. And that's a second shift in the way that we use spectral CT. That means that not only must we optimize the acquisition parameters, but we must also select the appropriate energy level, showing the highest contrast to noise ratio of the disease that we're actually looking to. And that's the way that we all have to think in terms of optimizing acquisition and optimizing the reading of the images that we have acquired. Now, here are some examples of the everyday use of spectral CT in clinical practice. This is an example of liver imaging and how the spectral CT will kick in. Of course, you have recognized that this is an MRI in a patient who is followed up after transarterial chemoembolization for hepatocellular carcinoma. And we're actually looking at that small nodule in segment 6, which has been the target of the chemoembolization. Now, if you look at the diffusion and the high B-value diffusion with the ADC map, clearly there's a restricted diffusion in this nodule, which is not a good sign after transarterial chemoembolization. But if you look at the arterial phase, 3D gradient echo T1 weighted images on arterial phase, even the subtraction map, you do not detect any hypervascular enhancement, which means that probably that nodule would be said suspicious nodule, and in terms of response, LIRA's equivocal response. Now let's look at the spectral CT scan that was acquired the same day. And here are the different sequences that we have reconstructed. The virtual unenhanced sequence, the arterial phase, monochromatic reconstructed energy level at 50 kAV. And why is this 50 kAV? Because in our practice, this is with all our systems today, the optimal energy level providing the highest contrast to noise ratio in the hepatocellular carcinoma population that we address. And the third sequence is the iodine over water map. Now, what do we see based on the analysis of those 3 sequences? Arterial phase, iodine over water. Clearly, this nodule still enhances. And this explains the restricted diffusion that we had. There is some lipidol, which is stacked here, but probably less than 20% of that surface. And we have hypervascular enhancement in the arterial phase. We have clearly some iodine within the tumors, which means this tumor is active. And it is not only active, but look, we have a washout on the polar venous phase, also acquired in multi-energy acquisition and on the delayed phase. So the response of that nodule is LIRADS treated viable tumors, which means that we have to reperform TACE. First example, dealing with liver imaging. Second example, dealing with pancreas imaging. This is a 46-year-old patient. The patient was referred because of the detection of on ultrasound of a nodule in the tail of the pancreas. And the patient was referred to both a pancreatic and liver MRI, and on the same day, a thorax, abdomen, and pelvis CT scan, anticipating that this could be adenocarcinoma of the pancreas, and we had to make the evaluation very fast. Now, this is the MRI images. So T2 weighted fat suppressed images, diffusion weighted images. We have the arterial phase of different segments of the pancreas. This is a subtraction map, and this is a T1 fat suppressed images. Now, what do we see? Clearly, we do see that we confirm that there's a lesion at the tail of the pancreas. And what's very interesting is that this nodule shows high signal intensity on T2, but with arterial phase enhancement. This is basically what we detected with MRI. We were challenged by that spot here, showing on T1 fat suppressed images. And we questioned whether that was actually some kind of artifact, because there was nothing on the diffusion maps, there was nothing on the arterial phase, we didn't see anything on the MRI. Okay, let's go to see the CT scan. Now, if you look at the same day CT scan that was acquired, again with the different sequences that you're familiar with, and this is the iodine water maps acquired at different segments of the pancreas. Well, we do confirm that there's a mass, enhancing mass in the tail of the pancreas, but we also confirm that we have several other hyper-enhancing nodules within the pancreas, both in the tail of the pancreas, in the body of the pancreas, and even probably in the head of the pancreas. Now, this is a multinodular hyper-enhancing map of the pancreas, which were confirmed to be neuroendocrine tumors, but with multiple masses. And that clearly shows how improved contrast can help in detecting hypervascular masses within the pancreas, and not only in one spot of the pancreas. Now, how do we perform those acquisitions? Now, this is just an extraction of the most frequently used parameters that we now have implemented on our latest system, which is a CT Apex dual energy rapid switching dual energy CT system. Some optimizations that we did was actually not going too fast with dual energy CT. And that's something that we had to learn, that the rotation of the tube, I would not go lower than 0.6. I think if we go too fast, we do not deliver enough photons, and we do not have a good quality of the images. With the CT Apex, we can of course have an 80 millimeters collimation, and this is the noise index that we have just set. Again, this is an evolving protocol. This is just to show basically what we use, and maybe we can discuss the different adaptations that maybe you have on your sites, and how we could improve our protocols. Now, again, using those kind of protocols has an impact on the way we detect tumors. This is another example to show in a patient who was scanned with colorectal cancer and scanned for the inclusion of in a therapeutic protocol at 2 time points. The first one was performed outside of our centers, and that was acquired in a polychromatic mode. And that showed faintly some hypodense lesion. And that was a repeated acquisition that we did on the CT Revolution. So our prior system without true fidelity reconstruction, without deep learning reconstructions. But clearly you can see that on the iodine maps or on the low KV monochromatic images, you can clearly better depict that metastasis in segment 4 of the liver. Okay, is that also shown in clinical practice? Now, this is a very interesting and very recent study. I like it because that's a study which actually looked at some high-end images compared to spectral CT. Now, this team from Denmark included 188 patients with breast cancer and suspected metastasis of breast cancer. They used a spectral CT, which was an icon, so the dual layer, dual energy CT. These are the parameters that were used, and this is the quantity of iodine that was used. Actually, I believe it's a high load of iodine, and probably, and we will speak at the end of my talk, we can reduce using spectral CT the quantity of iodine. But anyway, the interesting part of what the authors did in that study was that they included those patients and they compared what we could detect either when using a whole body MRI examination or a CT examination. And regarding the CT examination, the population was cut in half, some with dual layer CT being integrated in the analysis, and the others without using dual layer CT for the analysis. And they compared how many lesions could we detect on whole body MRI, how many could we detect on dual layer CT, how many could we detect with polychromatic acquisition. And this is what the authors found. They found a total of 1,009 lesions, including 320 METs and 689 benign lesions. And what the authors showed was the accuracy was higher for dual layer CT over that of conventional polychromatic CT. And it was even higher for lung lesions and liver lesions over whole body MRI. Now, to me, that's very interesting because I do believe that especially for the liver, whole body MRI should outperform CT scan. So of course, this study has to be reproduced and has to be tested, but this is very interesting. Whole body MRI was still superior for bone lesions, and maybe we can comment on that, on the limitation of spectral CT for bone lesions. Anyway, if you look at the way that the analysis was done, what's interesting is that, for instance, for lymph nodes, the authors proposed a new sign of tumor involvement within the lymph nodes, which is connected to the quantity of iodine within lymph nodes. That means that spectral CT actually provides a new semiology for different targets of cancer, such as lymph nodes. And of course, the authors also suggested that you could use iodine maps to actually quantify also the quantity of iodine within lung nodules, and especially small lung nodules. And I will show some images that have been provided in that paper, because I think they're very interesting. Now, this is just the accuracy curves. It just shows you that we're not far different from all the different technologies. The gap is close with conventional CT and whole body MRI, but still there are some differences. So let's look at examples to illustrate those differences. First one, which I think very interesting, is that axillary lymph node. Now, if you look at that axillary lymph nodes, and especially if you look at the iodine map, what you do find is that this axillary lymph node was measured, and the iodine load was actually very high. And if you look at the aspect on MRI, I'm not sure I would have just stopped that lymph node. If you look at the lymph node, there's still some fat within the middle. Of course, there's some high signal intensity on diffusion, but still, probably here, spectral CT can provide additional functional information on the way the lymph node enhances. So again, that brings new semiology, and that's a new way of thinking. And again, that means more time. Again, some examples of some nodules, just to show how disturbing that can be. Here's an example of a lymph node, which was not a metastasis. If you look at the aspect on diffusion, clearly that nodule within the lung is clearly visible here. But if you look at the iodine map, well, there's no iodine within that nodule. And actually, that was not a MET. And on the opposite, here's another patient with a small lung nodule, very small lung nodule. Probably that will be neglected by anybody doing oncology imaging here because it's so small. But if you look at the iodine map, well, there you go, a high concentration of iodine, and that proved to be metastatic. And of course, that was missed on the diffusion whole body MRI. Well, that brings us to more confidence, probably, to reading the lymph node, to reading our CT scan. But I think the main question behind is how do we integrate that to our workflow? Because the authors, and I think that was very interesting from them to do that. They assessed the reading time, and they showed that the reading time of dual layer CT was significantly longer than that of conventional CT. So for a long time, I believe that probably spectral CT could help us in better detecting lesions. And I must admit, as with AI, it doesn't take time from us. It brings us more time to make the interpretation of the images. Now, again, some examples to see how we can integrate that in a clinical practice. This is a patient with advanced hepatocellular carcinoma with pole vein involvement that you can clearly see. And this is the iodine map that was acquired on the arterial phase. This is the pole venous phase. And you can see how you can quantify the quantity of iodine that's within the pole trunk and the right branch. And you can see even the washout, the decrease in the iodine concentration on the pole venous phase. Now, why is that very interesting? Because you can monitor the response to treatment. And we performed in that patient transarterial radioembolization. And this is a CT scan performed 6 months after the transarterial radioembolization. And you can clearly see that the concentration of iodine has been significantly reduced. And you can provide a functional parameter to the referring physician. And you can provide that information in connection to the treatment that has been done. And if you look at the response after treatment, look at how you can clearly delineate how much the branch is, of course, still thrombosed, but that's not tumor anymore. On the opposite to that segment, where you still have some iodine concentration, you still have some active tumor, and probably you could direct a second transarterial radioembolization, specifically focusing on those areas with high concentration of iodine. Another example of the functional assessment of tumor response to treatment, this is a 50-year-old patient with renal carcinoma and bone metastasis. He was followed up under immunotherapy. This is the baseline CT scan with the arterial phase images, and you can see how you can quantify the iodine within that tumor. And this is the follow-up after the initiation of the immunotherapy. Now, of course, there's a response in terms of the actually the size of the lytic lesions. But what's very interesting is that you can monitor that you do not see anymore high iodine concentration within the residual lytic tumors, which are so difficult to assess. So we are not still at the point where we could probably replace MRI, especially for bone lesions, but probably we can provide more functional information to the clinicians and to the patient, mentioning how the treatment has been effective or not. And you know how that's important when you have very large heterogeneous tumors, such as this very large HCC. And what's interesting is that you can differentiate different components of the tumors. And this is just to show, in pink, you have the active portion of the tumor here, which does not have the same attenuation curve over the different monoenergetic levels as, of course, the aorta. So there's less iodine, of course, within these active tumors. But still, that active portion is still with a different curve than the global assessment of the tumors in terms of iodine concentration and, of course, of the background liver. So probably you can optimize, and again, targeted therapy, such as radioembolization, ablation, or transarterial chemoembolization by better improving tumor assessment and addressing where the tumor is active and where it's not. And probably if we could get some high discrimination between lipidol and iodine, could we probably also optimize the way that we follow patients with transarterial chemoembolization. Now, this is a very nice example where actually the lipidol and the residual active tumors curves do not match. But I have to admit, it's not always the case. And in many cases, the curves of the variation in attenuation of lipidol and active tumors is very close. So still, we have some optimization to do, and spectral CT with just 2 energy levels is probably insufficient to provide those distinctions in materials which show very close atomic numbers. Another limitation that we have is actually the assessment of bone marrow. Now, if we look at the number of cancers having an involvement of the bone marrow, it's a huge problem that we have. And that's where whole body MRI, of course, is interesting, because with whole body MRI, we know how magnificent this technique is to detect not the bone lesions, but actually the bone marrow invasion of the tumors. So I was very enthusiastic at the beginning, hoping that spectral CT could probably help us in seeing how we could better see not only the lytic bone lesions, but also the bone marrow infiltration. I must say that with the system that we have, with dual energy and only 2 materials decomposition, it's too difficult to detect all the lesions. Now, here's a nice example of a patient with a lot of bone marrow invasion. And if you look at the different maps, whether the fat over water maps, the iodine over water map, or the bone marrow edema map, it's very difficult to see the lesions. And probably you already see this high attenuation lesions, and probably you do not have enough advances with dual energy and 2 material decomposition. There have been some publications, especially using Siemens system, showing how the decomposition in 3 materials, iodine, fat, water, could help in identifying this bone marrow invasion. And I really think if we get there, then the CT scan will take a new spectrum in the way that we can address patients with cancers, because we will be able to see what's very difficult to see in CT, which is bone marrow invasion. So how can we improve that? I mentioned the terms confidence, and there have been several communications and papers, such as this recent papers using the ICON Philips system, showing how effectively we can improve the confidence that we have in addressing tumor behavior using dual energy spectral CT. The authors involved a small number of patients, 31 patients with 59 lesions with arterial phase hyperenhancement, and they tried to see whether using the ICON they could optimize the way that we can detect the washout. And if I go and show you some example, this will speak for itself. This is an example of a patient with a comparison of the conventional images, arterial phase, portal venous phase, and 2 virtual monochromatic images at 40 keV and 60 keV. And what you see here is that you can actually better, of course, depict the washout over that you see in unconventional CT. And probably, at least in that paper, the authors mentioned that 40 keV would probably be the optimal level to detect those lesions at 40 keV. But there are still some drawbacks. And here's a very nice example which the authors had the honesty to mention, is that you have to analyze with all sequences. This is another patient with HCC. This is the conventional CT. If you just look at the conventional CT, arterial phase, portal venous phase, delayed phase, I'm sorry, you clearly see that there's some hypervascular enhancement, which is nodular, and some washout. So clearly, if you only look at the conventional CT, you would say, okay, this is a LIRADS5 HCC with clear hypervascular enhancement and washout. But if you look at the late phase using 40 keV, now that's very interesting, because there's still some iodine and you gain some contrast. So there's still some iodine present. And the authors failed to detect the washout if they had only used the 40 keV sequences. Of course, if they use a 60 keV sequence, then they are more confident in washout. So again, the message is, using spectral CT, you have some sequences, you have to look at all the sequences, and that takes time. These are some examples of how spectral CT can help in detecting early lesions. This is from our institution at MONDOR. This was a patient with breast cancer and suspected liver metastasis. This is the April CT. This is the April 2021 CT scan performed on Revolution CT, and showing how you can detect actually the hyperenhancement, which is close to the lesions, and that appears before the lesion is actually measurable. And what we told the clinicians that probably there's metastasis coming up. Now, the clinicians, the oncologists, they decided to pursue with the same treatment. And sadly, in June, we were right. And those lesions had increased in size and were considered positive. And the shift in treatment strategy was performed in June. And of course, that brings us new questions is, okay, we can help in detecting more lesions, we can help in detecting earlier lesions, but does this change the management of patients? And to date, as that example illustrates, we fail to demonstrate that we can actually change the management of patients, the management of treatment, based on just early discovery of those lesions. Probably this will change, this takes time, but still to show the limitations of the application of innovation in imaging to oncology. Okay, this is just showing the lesion. Another example showing the benefits of using different sequences is that's a common situation that we find in oncology. Patients with a lot of chemotherapy, the patient with colorectal cancer with a lot of chemotherapy regimens, and of course the response of the liver to that chemotherapy regimen is of course chemotherapy associated steatohepatitis, and this is a patient who developed steatosis. Now, one of the benefits of using spectral imaging, as I mentioned, is that you have a couple of material decomposition that you can use. And one of that is that extracting the fat. And if you extract the fat, actually you have a kind of T1 sequence without fat suppression, which is this one. And what you do see is, as with MRI, when patients with a lot of steatosis and metastasis, you just look at the T1 in-phase images and you see those old lesions. And there you go. You can positive those lesions, which of course you could detect based on the enhancement, but so clearly and better seen on fat imaging. And that really takes some seconds. And this is just to show you how in clinical practice we do with our server. This is the GSI acquisition in a patient again with a steatosis, where we believe that we had to go to the fat map. This is the lesions enhancing on the polar venous phase. Okay, and of course you can see the steatosis. Well, you have your spectral acquisition, which is here marked by the GSI acronym here, Gemstone Spectral Imaging. And you can just shift that GSI and actually go to fat map. This is in French. This is the fat map. And if you go to the fat map, then you have a new sequence and you have a new way of seeing the tumors. And there you go. And those tumors just in liver steatosis, I find that fantastic that you have such a contrast between the hyperdense, or I should not say hyperdense, but the white liver and the black lesions, and that's actually the contrast you have. And for tumor segmentation, I think that could be very interesting. And of course, you have the added possibility to actually score the liver steatosis and to find a 28% of liver steatosis. So again, using new sequences can help you in optimizing the way you can manage different lesions and different patients. Now, can we improve the quality? I mentioned that. I think one of our goal is also to reduce the contrast agent dose that we have to inject to patients. But one of the questions that we had at Henri MONDOR, where we have a lot of HCC patients, is okay, we can reduce the dose in the arterial phase because this is a first pass imaging. But what about delayed phase? 3 minutes, 5 minutes after injection? Do we still have enough contrast agent that's still flowing so that we can actually see the washout of those lesions? So we tried an experience with 77 patients. 69 patients had primary liver malignancies, including 59 HCC and 10 cholangiocarcinoma. And we looked at those patients that were imaged previously with single energy CT, polychromatic CT, and the other ones with, and secondly with dual energy CT. So this was an inpatient matched control with standard CT and dual energy CT. What we showed in our work was that the liver enhancement and the contrast to noise ratio within the liver is clearly enhanced when you use spectral imaging, even using a reduced iodine contrast agent dose. So you have here the relative liver enhancement on the arterial phase, polyvenous phase, and delayed phase, where you can see compared to the conventional polychromatic CT, how we have enhanced the liver enhancement. What about the tumors? Well, if we look at the tumors on the arterial phase, you can see that you can better detect the arterial phase hyperenhancement. Even if you have reduced the iodine load, you still have a higher contrast to noise. You still have a higher contrast to noise ratios when compared in the same patients with a previous polychromatic acquisition. And that's at the same time, you can still have a better depiction of the washout of those lesions, even at the delayed phase. So for us, we do believe that instead of injecting 550 milligrams per kilogram of iodine, which is the current national recommendation in France, using spectral CT, you can actually go and reduce the dose by 1/3 without losing anything in terms of performance, whether addressing the arterial phase, the polyvenous phase, or the delay phase. And for us, that's an improvement in the quality, in the way we manage patient. And of course, that had already been demonstration for the arterial phase and the pulmonary phase in this very nice paper where the authors compared different also protocols comparing single energy CT versus dual energy CT with different iodine concentration. And they reached the same conclusion, was that you could actually improve, especially using low KAV images, you could improve the contrast to noise ratio of the liver, and you could probably also improve the way you could detect tumors. Now, in that paper, the authors did not focus on the tumors. That's why we believe that we had to show that there was also that input in terms of the assessment of the tumors enhancement. Now, what about locks and levers? Because the picture I just designed it looks magnificent. It's not always the case, and there's still locks, and probably we have something to improve in the way we use dual energy CT. The first one, and I will go back to the dose, and that this time it's the X-ray dose. We must not forget that when we compare a polychromatic acquisition with a dual energy CT protocol, to date, there's no modulation in the Z-axis. Now, that's a very tricky situation, because if you figure that all of our patients, or I would say most of our patients, they need a thorax, abdomen, and pelvis acquisitions. That means that when you use a polychromatic acquisition, you can modulate the milliamps that you can deliver, especially when you image the lung. Then when you reach the liver, you can increase the milliamps, and then you can also increase the milliamps when you reach, of course, the pelvis. And that's not the case using dual energy CT, which means that you have to kind of anticipate what could be some drawbacks of using dual energy CT, and which I will illustrate by this image. Now, this is the acquisition of an arterial phase focusing only on the liver in that patient who is a slim patient, who is not very fat. This is the arterial phase. That looks good. That was performed on the CT Apex very recently. And you look at the pole venous phase, and that looks noisy. Now, what's the difference? Well, you have to look at the CTDI that were used here, the IDSV here. Now, this is the IDSV that was used in the arterial phase, and that was close to 10. And that's what was used when we did the pole venous phase. Why was that? Because the pole venous phase was acquired together with the thorax, abdomen, and pelvis. So the system made a kind of a medium adjustment of the level of X-ray exposure that's necessary not to increase too much the level of X-ray exposure. And I do believe that in oncology, you have to be especially cautious on making sure that you do not get too low, especially in those thin patients, because you will lose the gain that you have in contrast, because you will degrade by having not enough photons reaching the patient. And that's a tricky part of the acquisition. So probably, and this is the example in the coronal view of that same patient, where you can see how you degrade the image quality on pole venous phase images. So what we decided was that in dual energy situation, in oncology situation, where actually X-ray dose is not the priority, I would say, in those very severely ill patients, we would probably have to stick, if we want to make a very nice liver imaging, to an IDSV of 10 milligrays, so that we can make sure that we can have an optimal delivery of photons to those patients. Second problem, of course, is very large patients. And again, this is with our high-end system. This is a BMI 47 patient that was performed on the Revolution CT without deep learning reconstructions. And when you look at that images, the question that you must raise to the technician is, hey, what did you use in terms of preset? And I went back, and there you go. The preset that was selected here, which is exactly the same value in the arterial phase, in the pole venous phase, that means that the technician did not override the system and selected an inappropriate preset, which did not deliver sufficiently number of photons to provide a good quality images. Again, you have to be very cautious in the way that you can program the parameters. And the technicians must be aware that they must select the good presets to deliver the X-ray dose that we need. And that has a cost. that has a cost in terms of dose. And I thank Milan Milliner, who is one of our leading physicists involved at Henri MONDOR. I'm sorry, the slide is in French. He just provided the figures yesterday. This is a comparison on the Apex platform of polychromatic acquisitions and spectral imaging, so dual energy, rapid switching, dual energy CT acquisition of the same protocol, which is the arterial phase of a multiphasic liver examination. And when you compare that, well, you see that the median CTDI that performed in those patients with different body mass index, of course, is very low. But when you use GSI, because we have placed that limitation around 10, stating that we must not go below, then the difference in terms of cost, in terms of X-ray exposure, is not negligible. Now, of course, we must put that in perspective, and we must not forget that in France, the national reference for dose in that setting will be 13 milligrams. So we're way below the limitations. But it's just that we pay more dose with GSI than we should pay with polychromatic acquisition. And I think that it's good to pay the cost because we have quality, because we reduce the contrast agent dose, because we improve with the different sequences that we have, the overall quality that we'll deliver. But we have to be cautious in the way that we deliver the X-ray dose. We have to be conscious of that difference in terms of dose. Can we go further now? Of course, implementing within spectral acquisition, the deep learning reconstructions as provided by GE is something that we tested, and we're very happy that we will deliver the talk at the upcoming RSNA. So we will provide the results. It's just a teaser, I'm sorry, but at the next RSNA, it's very interesting results comparing different levels of iterative reconstructions with deep learning reconstructions. But some of us already did that kind of work. And those authors, they actually compared the manufacturers' deep learning reconstruction techniques with a self-made, custom-made deep learning reconstruction algorithms working on agnostic vendor machines in a phantoms. And what the authors showed is that, and this was not on spectral CT, what they showed was that you could actually see how you can improve the detectability index using deep learning reconstruction. So I can tell you that the combination of spectral CT with deep learning reconstructions will definitely be a hit, because you will regain some contrast and reduce the noise with improved contrast because you use low KV energies, and you can reduce the X-ray dose because you can still reduce the noise. So clearly, just not mentioning what we will say at the RSNA, but clearly, probably that will be a hit, combining both to spectral CT. Tough work still to implement spectral CT in routine everyday practice. This is it's an old view, but just mentioning how spectral CT is not used at the same level by all radiologists, our department. And it's something that we have to think of, is how can we, with all the complexity that I showed, with the different sequences, how can we entrust radiologists to dive in spectral CT images? Well, I think that's a challenge, and it's the management of, it questions the management of the team. And for us, it's still a problem. And as I always say, changing is a problem. So when you're used to having just these poured images in the packs, having to understand the way that you could use sequences in CT is something which is still a problem. And when you see all those views of those different sequences, that looks like an MRI. Well, it's not. It's just a CT scan with just 5,000 images to read. Okay, that's something that we can address, and probably we can discuss that point in the coming minutes. Something, of course, if we change, we have to identify some new capabilities. I mentioned some of them, but of course that means that the team that you involve in have to understand that we have to get over habits, integrate the publications, and see how we can benefit and how our patients can benefit. And last question is that changing is a never-ending process. And of course, when you compare the different papers, okay, we all demonstrate the same thing. We all demonstrate that CNR is better. but what else? Does it change the management of patients? And I think that goes back to what Thornbury, radiologist in 1991, and Freibach mentioned, is that, okay, what's the efficacy? What's the actual level of evidence that we're targeting with spectral CT? And I think we're close to level 2 or slightly level 3. But I think we have not reached the patient outcome efficacy. And I think if we reach that, then that will be a game changer. Today, I think we're still between level 2 and 3. So that means that we have a potential to change the way radiologists understand the images and provide a good quality report. What we have to reach is the level 5, which is patient outcome. And with that, I would like to thank colleagues, a special thank to Rachida El Kadoui, who is an engineer at GE Healthcare France, and who helped me, especially having this nice video of the fat map in that patient with liver mets. Thank you very much. And of course, I'm ready for questions. I don't know if you hear me.
Sorry, I was muted there, but please go ahead. Now is your chance to ask questions to Professor Luciani. I could start with one question relating to your last slide, which of course is very intriguing, and we all want to show that we can change patient outcomes. I mean, it's our dream. So in which area, let's say you try not to make life too difficult for yourself, is there some area you think is particularly promising where you can really show that yes, it is true that if we, because of the new technology, we actually did change the outcome? What could you comment on that?
Yes, well, in my field, early detection of mets in patients where you could shift the treatment and show that you can either change the chemotherapy or introduce immunotherapy earlier would be good. The second thing, again, is bone marrow. If we can address bone marrow infiltration, that will be a game changer, definitely. And having the detection of tumors within the bone marrow will be so extraordinary in terms of CT, because you have the cortical bone. Yeah, sorry.
No, please continue.
No, you have the cortical bone, you have the lytic portion with the CT scan, which you do not have with MRI. And you could have the bone marrow infiltration. That would be just huge.
Yeah, because that was my question, that right now, if you combine with MRI, of course, it's much more expensive and complicated, but the diagnostic information, as you say, if it worked, it would be more diagnostic information if we could manage to, which is, of course, a fantastic goal for us as engineers and physicists, and the bone and marrow infiltrating carcinomas.
So should we go for 3 components? I don't know, more components, or maybe with photon counting that the problem will be solved. I don't know.
Yeah, I think it will involve quite a lot of work, actually, with quite a lot of teamwork to adapt it. And obviously, you want to see the infiltrating cancer. So
exactly. And
you wouldn't mind too much about the color or etc. But it's definitely a very interesting challenge. So any more questions out there?
Mats Persson would like to ask. Yeah, please.
Yes. Mats Persson, Professor Persson, please go ahead.
Yeah, there was somebody else speaking. I don't know if I interrupted them. So
you can go first, and I will come later.
Okay, thanks. So thank you for this very interesting talk. I'm wondering if you are mostly looking at the enhancement in terms of absolute CT numbers, or if you are, to what extent you are looking at the inhomogeneity or the shape or the structure of the enhancing part.
Today, yes, you're right. We're only looking at the difference in terms of enhancement or of the iodine concentration. In terms of texture analysis, we have been trying to do that with team co-worker Sébastien Mullet. I must say that all the changes in the acquisition reconstruction techniques used make so much difference in the way that the software is actually analyze difference in the architecture, that we have just stepped back from that and have still focused on some kind of more easily amenable parameters. But I'm sure you're right. We should go further. But the question is, how much instrumentation changes and how that affects the results beyond the tumor itself?
Okay, thanks.
Okay, the floor is open.
Yeah, I have one question about the bone marrow. So when there are cancers in the bone marrow, will the fat components go up in the bone marrow?
It depends on the age of the patient. Usually, of course, cancers arise in more elderly patients where the bone marrow is more effectively replaced by fat. The problem is that the bone marrow is actually vessels, fat, and core bone. And the tumors is, I would say, some vessels as well. So in terms of contrast, the early infiltration of bone marrow is undetectable in CT and is detectable in MRI because of the diffusion and because you suppress the fat and you can see that those spots when you enhance. And that's how that happened in myeloma. And you know how much in the multiple myeloma patients, it's so easy to detect those lesions with whole body MRI. So difficult to detect all the lesions in CT. It's, yeah.
Okay. Yeah, I think if we have some GSI data sets, we may have some studies to take a look on different pairs of materials. For example, fat hep pairs, something like that, or iodine fat pairs. So yeah, there are some unique features to see the cancers, but it's difficult to say what will be the features without clinical exams.
Right.
So.
It's challenging. I understand that.
Yeah,
but
yeah.
On the clinical perspective, that will be very interesting.
Yeah, I think when we do the gout study, so we collect some gout exams from field and we do different pairs of material decomposition. So we do the water hep or uric acid hep.
Yes.
So eventually we find some features for the gout.
Okay.
And very easy to detect something maybe because we do the tooth material decomposition. So technically we only can identify two materials, but we can different types of basis materials. So if we have clinical exams, we can analyze which two pairs of basic materials more sensitive and provide more features for this kind of detection job. So
I'm ready to work and to have some ideas. No problem. Yeah.
Yeah.
Any more questions out there? Or I have a question regarding how we have this extra energy information, and then you can plot this in many different ways. I mean, you showed it in your presentation. You have the Z map, you have the fat map, you have the iodine map. You have also the mono E, all the mono E images you can jump on. So suddenly it's 1,000 images. Do you really need all of them, or would you say that some of them are superfluous?
I think for everyday use, and that's actually what we send to the PACS. We send the virtual on contrast, the low KAV images, and the iodine over water maps. That's systematically sent to the PACS so that every colleague can easily use that. The fat map is not sent to the PACS, and that all the other maps are derived from the server analysis. But what's very important is that we send the metadata file to the PACS, and we are lucky that the PACS accepts that because that allows us to have a history of all our patients, and we can reconstruct whatever material we want, even if it's 1 month, 2 months, 1 year, 2 years, 5 years ago. And I think that's very important if we want to improve clinical practice, and especially in terms of patient management, we must archive those metadata files. I think it's very important, and we have to make sure that the ITs understand that and make sure they can accept the large quantity of information.
What do you think of I'm just speaking my thought here, but let's say you have one mono E with the highest spatial resolution with the best SNR, and then on top of that, you could flip and see all the materials with different colors, basically like fat and iodine and et cetera, basically all in one, and you could choose to see either the black and white. What do you think about that idea for the future? Is that stupid or
no, that would be excellent in terms of a reading help to assess, in a fast track, detect the way areas of different compositions. And again, as one mentioned by one of the colleagues on the podium, how your eye can be attracted, or a computer must be attracted by difference in the repartition of those different materials within an area, which clearly matches with early infiltration or early distortion or early disease. And I think that would be very interesting, having that, and of course testing that. Yeah.
Okay, thank you. It's 5 o'clock, and time is running out for us. Are you fine with that, everybody, or do we have one last question? No? Okay. So I would like to close this up. Thank you very much, Professor LUCIANI, for attending the seminar, and thank you all. Great having you.
Well, thank you for this very nice invitation and the talks, and ready to continue with those discussions and collaboration. I will be happy with that. Yeah.
Yeah, we would very much look forward to that, Professor LUCIANI, and thanks again for your time. This was fantastic. Thank you so much.
Thank you very much. Bye-bye.
Bye.
Bye-bye.